In this lecture on obstructive jaundice, we're going to focus on the things that we didn't cover in the gallbladder lecture. That is, we're going to go for primarily painless jaundice from obstructive pathology. Let's first review our advanced organizer and review how we handle bilirubin in general. Prehepatic jaundice, that is going to be caused by hemolysis, that is red blood cell turnover, and reabsorptions of hematomas. Same thing, red blood cells coming back into the bloodstream. The rate-limiting step for bilirubin is conjugation, 2,3-UDP glucuronoltransferase. So if you have excess unconjugated bilirubin coming to the liver, that unconjugated bilirubin is going to accumulate. And so prehepatic jaundice is primarily unconjugated, that is indirect. There's a lot that happens at the level of the liver. That is, the bilirubin needs to be uptaken, converted, that is conjugated, and then excreted. And intrahepatic disease can be a dysfunction of any or all three. That's not useful in the way of breaking it down into simplicity. So intrahepatic disease is going to be genetic, Craigliner-Haar, Roeder's, Dubin-Johnson's, or it's going to be hepatitis, that is hepatocellular necrosis. This is going to be a mixed picture because stuff happens in between. And lastly, where we're going to go with this lecture is going to be what happens when you have an obstruction, that is posthepatic jaundice. Posthepatic jaundice is going to be either painful in the way of gallstones or painless in the way of cancer and strictures. Because the liver has conjugated the bilirubin, is trying to excrete it through the stool, an obstruction is going to lead in an elevation of the conjugated or direct bilirubin. Now, if this was too fast, I want you to watch the gallbladder lecture later on in the series or in the medicine content in order to get a really strong handle of bilirubin. But this is the overview, pre, intra, and posthepatic, and we're going to focus primarily on posthepatic. What happens normally is that the liver secretes bile into the biliary tree, it gets stored in the gallbladder, and then is excreted into the stool. Well, one thing that can go wrong is gallstones. And what can happen is a gallstone that happened to be in the gallbladder comes out and gets dislodged and gets stuck in the biliary tree. This is choledocholithiasis. This is gallstone disease. Gallstone disease happens all of a sudden. And when things happen all of a sudden, the system doesn't have enough time to accommodate. So you'll see only mild dilation, but you're going to see inflammation of the biliary tree and of the gallbladder. Cholecystitis, choledocholithiasis. So the patient with gallstone pathology is going to present with some inflammation. So because you're going to have some inflammation, you should expect to see an elevation in the temperature, that is a mild fever, an elevation in the white blood cell count, leukocytosis, and because of the inflammation, you'll have a positive Murphy sign. Now, I don't mean to imply all cases of choledocholithiasis will have a Murphy sign, that's cholecystitis, only to imply that you're going to have some form of acute, painful jaundice with some associated inflammation. The diagnosis of biliary pathology always begins with the right upper quadrant ultrasound. What you'll see is mild ductal dilation, and you might see cholecystitis, pericholecystic fluid, thickened gallbladder wall. The best test for evaluating the biliary pathology is the MRCP. The MRCP is better than the ERCP because it gives you the same visualization without any of the risk of complications. And the treatment for someone with choledocholithiasis is either ERCP where you go in the bottom and remove the stone, or a cholecystectomy with retrograde cholangiopancreatography. In general, the one you want to pick is ERCP because it's faster, and the cholecystectomy route takes more time to get done. Now, that's covered in more detail in the gallbladder lecture. Let's talk about now what happens if instead of this acute phase, you get progression over time. What's going to happen here is a cancer is going to eat its way in from the sides. It doesn't obstruct all at once. It just slowly eats its way in, giving less and less of a passage for that bile. Since this happens over time, the gallbladder has time to adjust. The biliary tree has time to adjust. What you're going to see is a thin-walled, distended gallbladder and massively dilated biliary ducts. This is going to be the case of stricture and cancer. Because there's no acute phase, there's no inflammation. So you won't see an elevation in the temperature, and you won't see a leukocytosis. You won't see a Murphy sign either. In fact, Courvoisier's sign is the palpable distended gallbladder. And there won't be any pain. The first step is to get a right upper quadrant ultrasound. What you're going to see is the distended gallbladder and a massively dilated biliary tree. And the best test is MRCP, because you visualize everything in the biliary tree, and you don't have to put them at risk for pancreatitis. The treatment is going to depend on what the underlying diagnosis is. So either you're going to do an endoscopic ultrasound with biopsy, or you're going to do an ERCP with biopsy. And you may end up stenting or resecting. And that's going to be dependent on the underlying disease. So painful jaundice, choledocholithiasis, simpler in the way of which step do you do. Painless jaundice from stricture or cancer is going to require more diagnostic steps and more choices. So how do you pick? Well, you're going to get on a vignette very clearly someone who has a problem with obstructive jaundice. What you're going to see is either painless jaundice. And the thing about painless jaundice is that if you have a stricture or a cancer, because it can happen over time, the bilirubin can get quite elevated. And we're talking about 20 to 26. Whereas with choledocholithiasis, the liver hasn't had a chance to make a whole lot of bilirubin yet, so you're going to see single digits, 2 to 6. So really high values of direct bilirubin, especially when there's no pain, think painless jaundice. The other way you're going to get this is with clay-colored stools. Now this isn't common, but it's great for the boards. Bilirubin gives stool its color. So if you can't get bilirubin into the stool, it comes out as clay-colored. And they're going to tell you, hey, this is cancer, by saying, in addition, there's weight loss. So weight loss and clay-colored stool gives you the idea of some sort of cancer in the biliary tree. And lastly, if you have any mention of distended gallbladder, palpable and non-painful. If you have any of these in your vignette, you want to go to obstructive jaundice. And because it is painless, you know that it is not gallstones. If your obstructive jaundice were painful, you jump right to the gallbladder lecture and you take care of it. So in this workup for obstructive jaundice, what you're probably going to get is not the MRCP, because that just gives you the answer, but instead you'll get the CT scan. Not that the CT scan is the preferred test here, but it's the one that you're likely to be shown or given and asked to choose what to do next. And here's how it works. If that CT scan has obviously a pancreatic mass, well, you don't need to do that MRCP. You're pretty sure what it is. It's pancreatic cancer. And pancreatic cancer is particularly bad because it grows in the peritoneum. It doesn't bump up against anything, so it can grow for a long time and metastasize prognosis is abysmal. But if you've got pancreatic cancer or the test wants to tell you it's pancreatic cancer, look for migratory thrombophlebitis. It's thrombophlebitis that comes and goes on its own on different extremities. They probably won't show you a picture. They probably won't explain it. They'll just give you the words. Migratory thrombophlebitis is pancreatic cancer. The diagnostic step is going to be endoscopic ultrasound with biopsy. The pancreas is outside of the lumen of the biliary tree and the small bowel. And so the endoscopic ultrasound allows you to look through the wall to identify the pancreatic mass and make sure you biopsy it. So endoscopic ultrasound is best for pancreatic cancer, and the treatment isn't going to involve the Whipple procedure, where at the very least you remove the pancreas and the duodenum, often parts of the liver. Even with resection, prognosis is abysmal. Most people die in 6 to 12 months. So instead of that CT scan showing you a pancreatic mass, if you see something coming from the biliary tree, and this might be where they give you the MRCP instead, think cholangiocarcinoma. Cholangiocarcinoma has an increased incidence in those people who have primary sclerosing cholangitis, so they may give you the MRCP showing you the beads on the string. You're like, it's PSC. But now they're talking about some sort of malignancy. They want you to go after cholangiocarcinoma. And because cholangiocarcinoma is in the lumen of the biliary tree, the ERCP with biopsy is better than the endoscopic ultrasound because you'll be able to see it as you go up with the camera. Treatment is with resection. And lastly, if that CT scan shows you nothing, but you very clearly have an obstructive jaundice, this is where I want you to think about the ampulla of Otter. The cancer there, even though it's really small, so it won't be picked up by the CT scan, exists right at the exit of the bilirubin into the small bowel, and therefore can cause pretty significant obstruction. What I want you to think of here is if you have FOBT positive, but a negative colonoscopy. And you use the FOBTs to screen for colon cancers because those malignancies in the colon flick off blood and they become positive. But the colonoscopy is negative, which means that that blood must have flicked off a little earlier, and the ampulla of Otter is literally in the duodenum. So people who are FOBT positive but negative colonoscopy and obstructive jaundice, they're trying to tell you ampulla of Otter. In the same way as the cholangiocarcinoma, because it's intraluminal, the best test is ERCP with biopsy. You may even be able to see the malignancy at the ampulla before you go into the biliary tree. Treatment is resection. Now this whole time, you might instead just have a stricture. We're talking about the different type of cancers. That's going to come up a lot in surgery. But just as a throwback, remember, you might just have a stricture. And strictures can be treated with stenting. Except in PSC, where they should not be. Because in primary sclerosing cholangitis, you're going to have to do a transplant. And if you stent somebody, it's going to be harder to do the transplant. So in those patients, use ursodeoxycholic acid. So if we take a step back, we didn't really learn a whole lot new if you've been following through with this course. I want you to see the approach to jaundice in general, pre, intra, and post-hepatic, unconjugated, mixed, and conjugated. Then notice the difference between painful jaundice, which is going to be gallstone-induced, have mild dilation and then inflammation, versus stricture and cancer, which won't have any inflammation and has thin-walled distended gallbladder. Where you're going to go on the test is identifying each of these different cancers based on risk factors. FOBT positive, negative colonoscopy, ampulla of Otter. Migratory thrombophlebitis, pancreatic cancer. Primary sclerosing cholangitis, cholangiocarcinoma. The test you want to pick is MRCP, but the test you'll probably be handed is a CT scan. And don't forget about strictures, which can be stented unless it's PSC, in which case you use ursodeoxycholic acid. That's obstructive jaundice.